I've actually never been in a fight. Ever. Because I just don't fight back.
So you've just been attacked?
I've been beat up multiple times.
Oh no, Chris.
But never have I been in a fight.
Like I respect that, I guess.
Yeah. Anyway, welcome to the Guardian Test Prepped Back to Basic podcast. Today we are talking about, this is the third installment in our pediatric.
If you rewind a few weeks ago, Chris said we might break up this lecture series and not do 3 in a row. And then he said we were going to do 3 in a row. And then I criticized him because he had told me a little bit ago that we're not going to do 3 in a row. And then he's like, yeah, we might not. We might. And then now we are. It just ended up being 3 in a row. The whole thing was pointless.
It's not pointless. It's 3 in a row.
But anyway, thank you for your feedback. There have been lots of people giving us good feedback about this little series. We might consider doing a little mini series like this again, where we kind of take one topic and we break it down and over 3 episodes or something like that. Or
yeah.
2 or 3 episodes.
So this is the third of our basically pediatrics. And what we're really talking about here is pediatric assessment. But going through a systematic rule of pediatric assessment. The first week we talked about the assessment itself, what that should look like, how do we systematically go through that so we don't miss anything. Second week we talked about respiratory emergencies, because really our assessment in pediatrics, we're looking in the emergency side of things, we're looking at, can we recognize sick kids who have the potential to decompensate and intervene early to prevent that. And the main 2 things that are going to decompensate a child, or main 2 emergencies that are going to put them into cardiac arrest, are respiratory emergencies, which we covered last time, and shock. And today we're going to cover shock.
Cool. Any sponsors?
No. I couldn't get any. I was just kidding.
Prepare.
No, sorry, I couldn't get any. No, actually, we do have a sponsor today. So our sponsor today is, we're going to sponsor ourselves, is Guardian CME, because I want to just let people know again. So please so Guardian CME, we started as a way to share this kind of content, as well as content from other podcast providers in the EMS field, and some original content that we'll be putting out, basically to offer 100% free CAPC credits to our users and to our viewers.
Continuing education credits. Wherever you're at, continuing education credits for EMTs, MFRs, AEMTs, paramedics.
Yep.
And potentially in the future, not right now, ICs.
Yep, exactly. So I just want to encourage our listeners, go to guardiancme.com, get registered there so you can get some credits, but also let your departments, let your companies and states know as well. Like I said, we really want people to recognize that this truly is a high quality free resource and that it's available to them. So just let people know. So that will be our own sponsor today. But yeah, let's jump into it. So I know last time we covered kind of the respiratory side of things.
Yeah.
But today we're talking about shock.
We'll do a quick review. All right. Initial assessment when we approach a pediatric patient is a little different. It's not your general impression and, conscious, not conscious sort of thing. We're going to add the pediatric assessment triangle on top of that. Remember, the PAT consists of ABC. It's different than your primary assessment. It's ABC, and it's their work of breathing, which is B, their airway.
No, it's not.
Or their appearance. I'm sorry. It is. Appearance.
Right.
Yeah, their appearance. So their general appearance, meaning like, do they look like they have shocky symptoms? How's their skin? Stuff like that. Their work of breathing, how they're breathing, what it sounds like, and then their circulation. And we talked a little bit about in the PAT when we talk about appearance, how we also refer to like behaviors and things like that. How's their tone? How's their interactiveness? How are they engaging with their environment? We went into detail with that. So you would start as you approach a pediatric patient with the PAT. You'd move on then to your normal ABCDE. So airway, breathing, circulation, disability, which refers to like neurological disability, how they are neurologically functioning.
And then when we talked about the AVPU scale. So are they alert? Are they alert only to verbal? Is it to painful stimuli, or are they unresponsive?
Which is going to be much easier with a pediatric patient than something like a GCS score or an ANO times 4 reading, because it's a pediatric patient. Maybe they don't speak on your same level, right? And then we talked about how mom and dad can be a big resource, how a caregiver can be a resource. How are they behaving? Do they behave normally from what they normally do, or is it different than now? How are they feeding? We talked a lot about different assessment techniques. And then lastly, E in that assessment would be exposures or environmental factors that play in a role. So this is where we talk about like trauma, poisonings, environmental emergencies.
And I think that part of that E is also like exposures, like reminding yourself to expose the whole patient for this. Like, do they have signs of burns or, things like that? But really, even for some of our other ABCD, like even breathing and stuff, exposing the patient to see if we can truly see their work of breathing. And again, the whole premise here and the reason we present this systematic approach is that you're asking yourselves a couple questions. One, is the kid sick or are they not sick? If they are sick, based on our assessment, is this a respiratory emergency or is this a shock emergency? If it's a respiratory emergency, like we talked about last time, what are the 4 different types of respiratory emergencies and which one do I need to, consider? And as I go through this, I'm intervening. If I think it's a respiratory emergency, I'm going to give them some oxygen. If I think it's a upper airway emergency, then maybe I'm going to do this. And then the same thing on the shock side. So if we don't think it's respiratory and we think it's shock, what are the different types of shock and what interventions should we do? And now you may not, I was gonna say, you may not know if it's one or the other, or it may be a component of both, but we want to be thinking along those terms the whole time.
Yeah, we kind of want to know which came first, the chicken or the egg with this situation, because you can have shock emergencies that play into respiratory distress and failure, and you can have respiratory symptoms that could put you potentially into shock. But typically it's going to be pretty obvious which one's coming from where. And we build the systematic approach for you. I mean, we didn't build it, but it is built for you so that you can, this is going to be 1% of your patients. 1% of your patients is pediatrics, and 1% of that probably is going to be severely ill pediatric patients. So it's just not something that we do a ton. So it's something we need to train heavily on so that we're prepared for that rare circumstance. If you remember when we talked about respiratory emergencies, the first decision we tried to make was, are they in respiratory distress? Or are they in respiratory failure, right? So is this something where they're compensating or they're decompensating? And now as we move into talking about shock, we're going to first decide, do we believe based on the symptoms that we're seeing, because we are at the point where we can be taking vitals and using tests, and the assessment that we've done so far, do we believe that they're in compensating shock or are they decompensating? We talked a little bit in the last couple episodes about, how pediatric patients decompensate very quickly. Mm-hmm. So they're going to compensate for a long period of time and they compensate very effectively. But when it's time for those compensatory mechanisms or making up for the fact that, body systems are not at optimum capacity, right? When it's time to decompensate, they crash very quickly. So we need to be able to recognize the signs of compensation and decompensation quickly so that we can act on them and realize when we're kind of in that impending decompensation phase.
Mm-hmm.
So
we say too, especially when it comes to like shock and stuff, like if you're seeing like later signs, like, and we'll talk about like blood pressure and things. I mean, we say you're a little bit behind the 8 ball, and we don't mean that like you messed up and that's why they're decompensating, but like it is going to take more aggressive measures to resuscitate that patient, because like you said, it's much more of a quick fall off and decline once pediatric patients do start to decompensate versus when an adult does.
For sure.
So
let's just talk about decompensation versus compensation. Can you just kind of explain to the folks sitting at home what the idea of compensation is, in case they're, just break it down back to basics. Like, what is compensation?
Sure.
When we say that, what do we mean?
Yeah. So when we say compensation, we mean that the body is in its own way doing things to make up for whatever issue it's presented with. So like on the respiratory side, like you're breathing more rapidly to bring in more oxygen or to blow off more CO2. Your heart rate goes up because you need to increase your metabolism. These kinds of things that the body does. When someone's decompensating, it means that those compensatory mechanisms have either failed, meaning that maybe they're still happening, but it's not working, and we're seeing new signs and symptoms that things are getting worse, or that they've stopped all completely, where we're no longer. So like this is like the asthmatic patient who now is, you haven't done anything, they're breathing rapidly, and now they're breathing shallowly. It's because they can't even breathe rapidly anymore. Their compensatory mechanism has stopped at that point.
Yeah.
Or the asthmatic patient who is breathing heavily but continues to get more and more hypoxic, right? I mean, so both of those kind of things can happen. So
yeah. I think the easiest example of compensation is simply if my blood pressure is dropping because I'm bleeding out,
mm-hmm.
my heart will make up for that by increasing my heart rate in order to increase my blood pressure,
mm-hmm.
right? So if I'm 120/80 normally, and then you cut my arm off and I start bleeding out, my heart rate might go up well above 100 to keep my blood pressure at 120/80. As soon as my blood pressure starts to drop below 100 systolic to dangerous levels, well, guess what? It doesn't matter that my heart rate is cranked up. I'm now decompensated. It's not, like you said, it's not that it's not still going. It's that it's not making up for the issue anymore. Right?
Exactly. Yeah.
Compensating for something, you're making up for it. Right.
Yep,
We always
exactly.
say, like we taught in our lessons, guys drive big trucks because they're compensating for something.
Mm-hmm,
right.
Mm-hmm.
So Same thing with your body, right?
Right.
I drive a very small truck. I drive a Ford Ranger. It's a 2012 Ford Ranger. You can look it up. It's one of the smallest trucks out there.
Good for you.
Yeah.
Cool. But yeah, so that's compensation, decompensation. So, but again, blood pressure is one marker of that, but it's not the one. I'm going to encourage us not to rely on blood pressure for pediatric patients as our measurement of compensation or decompensation. I think there's a couple other things that we want to look at. So first though, I guess let's jump into, just like in respiratory, we gave 4, we're going to give 4 types of shock. And this is probably going to be a review for some people, but we like to go over them and then go over them again in the context of pediatric patients, because what's going to put you into a type of shock as an adult versus a kid is different.
I think the most easiest and simplest form of shock that we think of when we think of shock is hypovolemic shock. And that is just simply hypo meaning low, volemic referring to volume, low volume, right? So not enough fluid in order to keep our blood pressure adequate to perfuse all our tissues.
Right. And this is one, and that's what, I guess that's another thing we should probably define when we talk about shock. What is shock? Shock is basically your body's inability to deliver oxygen to the tissues so that they can function. Right. Mm-hmm. So, and again, hypovolemic shock right off the bat is one where I think the first thing we go to in emergency medicine is someone bleeding out. That's not the hypovolemic shock you're going to see in a kid, right? I mean, 9 times out of 10, if you have a child who's in hypovolemic shock, it's not because their leg got chopped off and they're bleeding. It's usually because of severe dehydration. Yeah. It's because they haven't been eating, they've been vomiting, they're not drinking anything, and now they're hypovolemic and they're like showing signs of shock and, potentially decompensation, not because they lost any blood, but because they lost fluid. Like you said, it's not blood, it's fluid in their vascular space. Right. Which is causing a problem.
So how do we fix a hypovolemic shock issue?
Give them fluid.
We give them fluids, right? We increase the fluids, or we take the fluids that we have. We could consider things like pressors to take the fluids that we have and increase its ability to move around.
Sure.
But we're getting more into cardiogenic stuff then.
Yeah, yeah.
So that would be hypovolemic shock. Then there is cardiogenic shock. Cardio meaning the heart, right? So we're talking about a pump problem. So this could be something like a congenital heart defect. This could be something like in an adult, a lot of times we lean towards things like congestive heart failure, and kids can experience these things as well. It's just usually because of it's not from the same precipitating factors.
Right. Well, that's the thing. Like I said, again, in cardiogenic shock, like things like CHF, and like those are the given ones. But what about in kids? A kid can get congestive heart failure, but it's usually because they have some kind of congenital heart problem or defect or something going on. There's usually not a reason outside of that a child should have a pump problem, right? Their pump should be functioning fine unless genetically or, it didn't develop the right way.
Yeah. Now, would a tamponade be considered a cardiogenic shock?
Nope. We're getting there.
I know.
Okay. It was a test question.
I mean, I know.
I thought you were asking.
I wrote the script.
Okay. I just thought you were asking. I was like,
I was just trying to.
I thought this was going to.
Just because it involves the heart. What I'm trying to get to is just because it involves the heart does not necessarily mean it is a pump problem.
Because even in cardiac tamponade, again, it's the pump is working fine. There's something else going on.
So if there's an arrhythmia or something like that, you can claim that that's a pump problem.
Yeah. Yeah.
Right. So if you have an arrhythmia, the heart's not beating fast enough. It's beating too slow. It's beating too fast. It's not beating rhythmically because they're in some sort of arrhythmia. That would be a pump problem. Yeah. Right. How would we fix that? Well, it depends on what's causing the pump problem. Right. But it could be removing fluids like we do with congestive heart failure. It could be increasing ejection fraction by using things like chronotropics or inotropics, drugs that are going to increase contractility or the speed of the heart. Right. It could be pressors where we're kind of increasing the squeeze.
That's the one different thing with cardiogenic shock. So the only thing to truly treat cardiogenic shock to reverse it is some type of surgical procedure on the heart so that it functions fine. There's only a couple different surgeries that we can do. So there's a lot of times that's not an option. So what we're doing is that we're giving the heart a better chance. So we're increasing its squeeze. We're decreasing how much fluid is being pushed into it. We are speeding it up, slowing it down. We're augmenting the pump now to better optimize the pump.
Yes, exactly. I like it. So next would be obstructive shock. And obstructive shock is when we have obstruction of blood flow.
Right. So this would be cardiac tamponade or pulmonary embolism and things like that.
Right. Those are the two obvious ones. Yeah. Something that's blocking the blood flow from getting there, and therefore we don't have oxygenation of tissue.
Right. So there's plenty of volume. The pump's fine. The container it's in is fine, but something's blocking it from getting to the tissues. So cardiac tamponade is basically fluid around the heart that constricts the heart. The other thing you can see, and I think this is more of like where, again, a very rare case in kids in general to find an obstructive pathology. But I think we're not, cardiac tamponade is probably not one that we would think of in kids, but something like, like a myocarditis or a pericarditis where you start to get like inflammation of the pericardial tissue.
And that can be from infection, from a severe infection.
Exactly, from infection or something. That might be a reason that a child would have. I'd be much more apt to think if a child showed signs of, obstructive shock, I would much more think along the lines of like infection, like inflammation of that tissue, even like things like different autoimmune diseases that can cause like calcification of those kind of tissues. That before I'd think that like.
Tamponade, I was just thinking trauma. Kids get into trauma as they get into risky phases. So tamponade secondary to trauma, I could see. Yeah. But this is where I think it gets nuanced and people get frustrated. But like you got to think of it as in a tamponade or in like a swelling, like a myocarditis or something like that. You have swelling of the heart tissue that does choke out the heart. So it's hard to be like, well, how is that not cardiogenic shock? It's a heart problem. Well, it's not, because the problem isn't generating from inside the heart, right? So it's a problem that's affecting the heart.
It's the tissue outside of the heart, right? It's that pericardial tissue or that tissue outside of the heart. It's not.
It's
the
acting
pump itself is working fine.
Yeah. Yep. On its own. Cool. So, and then lastly, we would talk about, let's cover real quick. How would we handle obstructive shock issues?
Well, one, you got to alleviate the obstruction if you can, right? So whether surgically or whether, like a pericardiocentesis, if it's a tamponade or something.
PE, you got to bust the clot.
Bust the clot if it's a PE. But again, a lot of times it's going to be augmenting the heart in the meantime to help it, to optimize that pump, right?
And that's what we in the field have to do a lot more than, we're not going to be able to necessarily do super definitive treatments. We're going to optimize the pump and optimize the system until we can get them to those definitive treatments.
Right.
But it's important.
But again, understanding this pathophysiology behind the different types of shock really starts to make you think now, okay, well, what kind of medications am I going to use to augment and why, and what procedures can I do or can't do in the field, and how much fluid, right? Like fluid becomes a big thing, which I think we'll talk about, but like, in all of these shock states, initially a little bit of fluid is going to help the pump.
Yeah.
But if it's an obstruction or it's distributive or even like to what extent, right? Before now I'm making the problem worse.
Right.
Even we talk about compensation, decompensation, I can give medications to speed your heart up. That might help for a time, but I can't keep your heart sped up forever. Like it will decompensate. So again, we have to realize that, and we've said this before, everything we do in the field and in emergency medicine in general is to aid and assist the body in compensating and doing these things until we can get more definitive treatment, which a lot of times doesn't happen in the field. And a lot of times doesn't even happen for me as an ER doctor. I don't do there are a couple things where I do definitive treatment for, but otherwise it's stabilization, resuscitation, optimization, and then get them to the next step.
And then the last type of shock that we talk about is distributive shock, which Chris just mentioned. So distributive shock is there's not a pump problem. There's not a volume problem. There's not an issue with obstruction. There's no obstruction of flow, but the fluid's going to the wrong spot for one reason or another. So an easy example of like a distributive shock would be like anaphylaxis, right? Everything's working fine. We have an immune response where all of a sudden all my vessels dilate, right? So there's not blockage of flow and there's plenty of fluid, but relatively there's not enough fluid to keep that blood pressure up because all my vessels just dilated. So now my pressure is bottoming out, right?
And we see the same thing in septic shock, and we see the same thing in
burn. I think severe burns, we see fluid shifts that can very much relate to distributive shock.
Yeah.
Which is an issue, which is why, again, initial response, give lots of fluid, and then, because we got to keep the body going while we heal that.
Right.
Another version of distributive shock would be septic shock. Sepsis is a systemic infection or a systemic infection response.
Well, and really, I mean, SIRS, when we talk about SIRS, S-I-R-S, SIRS criteria, that stands for systemic inflammatory response syndrome, right? Yeah. So we don't define it sepsis until we have a source. So if I know it's because you have a UTI or I know it's because you have myocarditis, then I term it sepsis, but it's still a systemic inflammatory response system to some type of pathological agent, right?
Right. And the same thing's happening that we see in anaphylaxis a lot of time. You see dilation of a lot of different vessels. You have a distributive issue, and now you can't perfuse effectively.
Right.
Along with other fevers and then other infectious.
So what's the patient going to look like then, right? Because I said we don't want, like, I think typically we define shock a lot of times, and then the textbooks will do this, and the when you're taking a test, look at the blood pressure, right? I mean, one of the only ways I can tell you in a test that a patient has shock is to give you a low blood pressure. Sometimes, right? So in kids, though, that is not the sign I think we should look at. Now, obviously, if their blood pressure is too low for their age, very much this is shock. But though we talked about how they decompensate, so their blood pressure is not going to drop till very late. So what are the things that we're going to see in shock? So again, this goes back to that assessment technique, right? When we looked at the A's and the B's and the C's, am I tachypnic? Am I breathing rapidly, but don't necessarily have a respiratory reason to be breathing rapidly?
Right. If I have no obstruction of the upper airway, no obstruction of the lower airway, there's no way that I have some sort of neurogenic, disorder, control of breathing. What's explaining the fact that I'm breathing rapidly then? Well, I'm just trying to pull more oxygen in, so something's wrong.
Right. And if my body thinks it needs more oxygen, it's because it's not getting oxygen somewhere. And if it's not getting oxygen, but all the respiratory stuff's in place, then it's not getting oxygen because there's a circulatory problem, and I have a shock-like state, right?
Yes.
Heart rate will be the same thing, right? If heart rate is up, then what is my body trying to compensate for? Again, it's lack of oxygen to the tissue. So where is the problem? Is it a respiratory problem? And that's not so you can see how they both, you're going to see increased heart rate and increased breathing rate in both respiratory and shock-like states. But that's why we break it down systematically. So, okay, I think it's respiratory. They're tachypnic. I think it's respiratory. And they're tachycardic. Do they have an upper airway obstruction? Well, no. Do I hear any wheezing, or is there any history of anything that would give them no, they don't even have a history of asthma. Okay, well, is their temperature up? No, they don't have any signs of infection or anything like that. No cough. Okay, have they had a seizure or anything? And all of a sudden I'm like, well, I don't see any reason respiratory. Now I got to start thinking, well, why would they be tachypnic and tachycardic? Because maybe there's a shock-like state here. So now I'm going to start investigating those types of things.
What type of shock? How's their fluid levels? Is there a pump problem? What's their EKG look like? Has there been something that could have caused an obstruction, or can we find an obstruction somewhere, or are we having trouble distributing the fluid?
Exactly.
Right? So once we know these things, we can look for them, but we don't think that far down the line a lot of times. And that's what we're here to kind of walk you through and build your skills.
Other things we really want to look for when we're trying to differentiate whether or not a child has shock, and the big one I want to emphasize is capillary refill. Way before blood, not way before, but before blood pressure is going to drop, the patient's capillary refill is going to lengthen, right?
Right, because your peripheral perfusion is going to drop before your central perfusion does,
exactly,
right? So we're going to see that before we're going to see a huge tank in blood pressure.
Mm-hmm. And again, capillary refill is when you push on that nail bed, it should pink back up in less than 2 seconds. If it's taking 3 seconds, 4 seconds, that's delayed capillary refill. That is a circulatory issue. There is a pump problem, or there is a volemic problem. There is a shock-like state occurring, and we need to address that before that blood pressure drops, right? So breathing rate, respiratory rate, capillary refill. Again, even going back to their color. Are they pale? Are they cyanotic looking? Maybe it's not because of respiratory issues. Maybe it's because they're shunting all the blood to their core their heart can pump, you know what I mean?
Right.
And these types of things. So we need to consider those. And again, then as a last piece, what is their blood pressure? Right. But jumping right to the blood pressure, you miss all these different signs that can clue you in. And that's the whole purpose of the systemic approach, is to identify as early as we possibly can. Hey, this kid's sick. They're compensated right now. I think it's a shock-like state. So what am I going to do?
And I feel like if you can get that far in a pediatric assessment, you've pretty much solved the mystery, or you at least know what you need to do next to fix the problem, or at least stabilize the problem, right? So even if you're not really sure, I don't really know if this is a low volume problem or if it's a distributive problem, the answer might be the same. Initial fluids, give some sort of pressure, you follow your protocols, you do that. It's still going to solve, it doesn't matter which one of those it is right now. In the acute phase, it's going to solve that issue until we can get more data down the line in the ER.
And especially in EMS, just like the initial thing we're going to do with every respiratory, whether it's upper, lower, lower lung tissue or disordered control, what's the first thing we're going to do with oxygen? Same with shock. If we suspect any shock-like state, we're going to start with fluids. Now we have to be careful, right? And this is what I was kind of leaning to before, as well as we can't give too much fluid because that can make the problem worse. But your initial approach, whether it's a hypovolemic, distributive, obstructive, which one am I missing? Cardiogenic shock, the answer is always going to be fluids initially, because again, our job is to support the body to help it, compensate until we can get more definitive treatment. So so from a fluid standpoint, what are we going to do with kids? Like, do you want to go over that?
What do you mean? Like protocol wise?
Yeah, like dose wise.
It's going to vary, but for shock, isn't it
it's 20. So we're going to do
20 per kilogram.
Yeah, exactly.
If they're well, okay. So it depends on your local protocol, but some protocols will call for 10 per kilogram if they are currently stable and compensating, and 20 if you feel that they are decompensating. But that's going to completely depend. Sure. That's kind of a PEP thing.
Okay. Then the AHA, like the textbook answer is like, what's the initial loading dose of IV? It's 20 mLs per kg. So again, I can see why you'd want to do a little bit less if they look good, because again, you give one bolus, and even with adults, I mean, you give one bolus and nothing happens. You give a second bolus and nothing happens. Especially in kids, you need to stop now and think, okay, why is nothing happening? Why are fluids not helping me at all? Right. Because if they're not helping, any more is probably going to harm. Yeah. Those first 2 bolus doses are probably fine, but again, why is it not working? Maybe now I need to look more at like pressors or other types of things.
Right. So hopefully this allows you to have a little bit more of a systematic approach to how you're going to assess pediatric patients. We're going to be talking about cold emergencies in a couple of weeks. And I just thinking when you were saying here, it reminds me of like, so let's say we check cap refill and, oh no, the reason they have poor cap refill in their finger is because it's cold outside. Well, where would we have caught that? Well, we would have caught it when we assessed for exposures in the ABCDE, right? So as long as we're following this order, I really think that you're going to solve this mystery, or like I said earlier, at least get to the point where you know what definitive treatments need to be done, or sub-definitive treatments need to be done to stabilize them until they can get to the right place. Mm-hmm. And that's the job, right? It's to balance them, it's to keep them safe. So I think that if you follow these steps, you start with that PAT, you move on to the ABCDE, you start gathering data through vital signs and history, and then you start to in your mind, definitively decide, okay, are we dealing with an airway issue, or are we dealing with a shock issue? If we're dealing with an airway, are they compensating? So are they in respiratory distress, or are they in respiratory failure and they're decompensating? And if it's a shock issue, then are we dealing with compensated shock or decompensated shock? And then once you know that, okay, well, what type of airway issue? These are the 4 kind of hot topic ones. And then what type of shock am I dealing with? Okay, this might change my treatment a little bit, mm-hmm. right? But in general, it's going to get you where you need to be.
And the reality is too, like I said, without being redundant, like if you truly do the pediatric assessment triangle, so if you truly look at their appearance, look at their work of breathing, look at their circulatory status, then engage with them and do your A, B, C, D, E, and then move on to your secondary assessment and get a full history, sample history, do a head to toe physical exam. And all along you're asking yourselves, are they sick? Are they not sick? Is this respiratory? Is this shock? What type of respiratory? What type of shock? Are they compensated, decompensated? And you get to the end of that whole assessment and you haven't found anything, you can take a deep breath of relief knowing that like there's a very unlikely chance that you are now going to transport a kid who's going to decompensate on you or has anything going on that you need to more emergently address.
Right.
And even if you don't get to that answer, but along the path, recognize that something's wrong, you will start down a path of giving oxygen or giving fluid, so that even if you never got to that exact answer of what's going on, you still treated the patient in a way where you prevented further decompensation. So a lot of times I think in EMS it's difficult because you guys don't get to see the outcome, right? Like you don't necessarily get to see what the definitive treatment was at the very end or the definitive diagnosis. And maybe even I don't as the emergency department physician, but those actions we take are what sets these patients up for success and recovery, even when we don't know it. And that's why this systematic approach, like you said, we see kids a lot less than adults. So having this and doing this every time, I mean, again, the next 55 times you use this, you might find nothing wrong every time. But it's that one time where you're like, oh, weird, the cap refill's off, that makes you and clues you in, that again, then allows you as the EMS provider to set that patient up for actual recovery and resuscitation down the line. So cool. Awesome. Well, again, if you guys are looking for continuing education credits, 100% free CAPC CME at guardiancme.com. We'd love to have you come over there. And again, you listen to a clip like this and take a quiz and get a certificate and you're good to go. And again, please reach out to us. Let your colleagues know, let your departments know, let your state departments know that we are here and we are happy to help. So hope you guys have a great week and we will see you next time.
Stay sweet.
Hey guys, thanks so much for taking a listen. If you are studying for the National Registry exam, we're here to help. We have a National Registry prep program to help you pass that exam. Check us out at guardiantestprep.com. If you'd like continuing education credits for listening to our podcast or watching this on YouTube, follow us at guardiancme.com. 100% free CAPC credits. No matter what state or country you're in, we're here to help. So again, we thank you so much for listening. We hope you have a wonderful week.